God, we thank you for the fact that we are able to put this together. We thank you for the persons who have initiated, oh God, the Flame Ministry. Oh God, we thank you for the vision. We thank you, oh God Almighty, for the mindset and, Lord God, giving us a mind where we can come together and discuss matters concerning us as a man. Father, we know it is your will that we prosper, oh God, in good health. And so, Father, we thank you for even the persons who would have made themselves available. Father, we pray that as we go through this session, that, Lord God, it will be very informative and also transformative. Father, we pray that as we continue to listen in, that, Lord God, will continue, Lord God, just to receive all the blessings and the thoughts that are going to be shared here on tonight. Oh God, bless us, Lord God. We open our hearts and our mind. We invite you in this session even right now because, oh God, we don't want to do anything without you. And so we acknowledge you in all our ways. We pray for direction throughout tonight's session. Father, let somebody leave this session, oh God, being informed and transformed. Help us, oh God, to take our health, oh God, and everything that concerns us, Lord God, where we can glorify you in any way, because without our body, without our health, then we can't glorify you to the fullest. And so, Lord God, we thank you once more for this opportunity and for this time. Oh God, bless us even right now. Bless, oh God, the speaker, that our guest speaker. Bless, oh God, the moderators, and all those who will be involved throughout the rest of this session. And for those who would have come on, especially, oh God, we thank you for them, and we thank you for those who are about to come on as well. Father, help us to even continue to share the word even now, that someone else can join in and be a part of this great and wonderful session. Bless us now, and we say thanks to you. In Jesus' name we pray. Amen and amen. God bless you all in Jesus' name.
Amen. Thank you so much, Brother Adrian. Well, as I said, we're just returning from a little summer break, and I'd just like to welcome everybody to our family life and marriage enrichment session, where we keep the flames alive for all of us to keep informed, to keep well. And so tonight is no different. We use the acronym FLAME, coming from Family Life and Marriage Enrichment Session. So we have the flames that keep us alive. My name is Sister Theresa Nepaul, and I am the person who had this vision to bring our team together. We work together as a team, a wonderful team that's always bubbling and coming together to put on special programs for you. Tonight we have a very, very special program. This is the month of September, and in Jamaica, we celebrate this as an awareness month for prostate cancer. And this is something that we don't want to be spreading. We want everybody to be educated about it, to be able to share and to care for all those you come about, whether at workplace, at church, wherever. And we have special people that are going to be taking us through the education part of this. And so, Brother Kevin, I asked him to play a family song for me. Could we just have God? Thanks. We are family. Wherever you're coming from tonight, you're special to us, and we want to welcome you. And in a while, Tanik is going to be recognizing some of our special guests tonight. But right now, I'm going to be asking Del Marie to come in with our usual icebreaker. Over to you, Del Marie.
Greetings, everyone. As
Yes.
Evangelist has indicated, we have been out for a little bit, but we are back, and we are back live and ready to go to share some very important information with you. And of course, we start off with a little icebreaker, and this icebreaker is really relating to tonight's topic as it relates to prostate. And I would love, you're seeing there how to join. We're doing a Kahoot. We have 15 questions and it's on the topic. So I'd love for the men to join. Men, please start joining. So you go to the website. So join at www.kahootit. Or if you do have the app, then you can just click on the app and then you enter the game pin that is indicated there. So go ahead quickly, gentlemen. Sign up, waiting for you. Waiting for you, gentlemen.
You might have to ask the ladies to join.
Come on, gentlemen. I don't want to have all the ladies joining. It's your night. Right, Papa Doc. Welcome, Papa Doc. Come on, who else is going to join Papa Doc? We can't have Papa Doc alone in this. Thank you. I hope Nikki means Nicholas or Nicoy. All right, so we have Nikki and Papa Doc. Come, let me have at least another 10 quickly. Come on. Mackenzie, thank you. Coming on. Great, so we have 3. Can we have some more? At least 7 more, we will be good. Can we? Come on, gentlemen. Professor. So we have a doc and we have a professor on board. Come on. Come on, gentlemen. Come on. Come on, gentlemen.
Adrian,
Val,
you're not entering?
thank you, Val. I see 50 persons on, and I'm sure majority will be, should be men.
Just a second.
All right, so I give you another 2 minutes, so we start in 2 minutes.
Come, Porter, join us.
All right, just go to the website, Thank you for coming back on, Nikki. www.kahootit, and then you enter the game pin. Or you can just scan the QR code there, right there, and it should be on. So you can try either. So I'm down to 3. What happened to Professor? Professor Mackenzie, welcome back. All right. Remember, you can scan the QR code and it will take you right there, or you can join using the website address there, and then you enter the game pin and you should be on. Thank you, Fogo. And we are missing one again. It looks like Nikki is off again. All right, Professor is back. Nikki, you're still out, and we are waiting as we count down. Going to just a minute, so we have 5 on. I guess we're gonna start with the 5. If you want to join, you can join later on. Thank you for coming back, Nikki. We have 6, so let's go. We're gonna start. All right, so as I said, this is relating to the topic of prostate awareness, and we start in 2, 1. All right, so the first question, the prostate is part of which body system in men? Is it the digestive system, reproductive system, circular system, or nervous system? Remember, we are looking on this. You can use another device to answer. Remember, look at we have 2 answers in. Come on, we have 6, 3 answers in. All right, good, right. And so the answer is reproductive, and all persons got it correct. But let me see who got it right first. And it's Professor. No wonder he's a professor. And let's move on. Papa Doc, come on. I expected the Papa Doc to win, you know. So let's move. Second question. Which age group is at higher risk for prostate cancer? Is it under 20, 30 to 40, over 50, or all ages are equal? We have 4 answers in, and the answer is over 50. So 2 persons got it right. Let's see. Papa Doc, that's the expectation. Papa Doc is on top as we move to question number 3. Which of these is not a risk factor for prostate cancer? Is it family history, diet in high fatty food, African or Caribbean ancestry, or is it drinking plenty of water, which is not a risk factor? We have 4 answers in and 4 minutes to go. 2, 1. All right, and the answer is number 3. Well, 3 persons answering correctly. Drink plenty of water is certainly not a risk factor. And we see here Papa Doc remaining on top and having the highest streak of winning for 3 questions consecutively. Question number 4. Which of the following can be an early warning sign? Is it frequent urination, pain in lower back, hips, or pelvic, blood in the urine, or semen, or all of the above? Which is the answer? And we have 1 answering correctly, all of the above. Let's see if it's Papa Doc. And it's not Papa Doc, it's Professor, but Papa Doc is still leading. As we move to question number 5, what does PSA stand for in prostate cancer? Is it prostate specific antigen? Is it prostate safe analysis, prostate screening assessment, or personal safety alert? 2 answers in as we close down to 1. And the answer is prostate specific antigen. Let's see who got it correct. And it's Papa Doc. All right, Papa Doc, you're really a doc here. So let's go to number 6. Which lifestyle choice can help reduce the risk of prostate cancer? Is it smoking more, avoiding exercise, eating balanced meals with fruits and vegetables, or skipping doctor checkups? Which of them can reduce the risk of prostate cancer? 3 answers in, and the correct answer is blue, eating balanced meals with fruits and vegetables. Let's see the scoreboard, and leading is still Papa Doc. As we move to true or false, prostate cancer always shows symptoms in its early stage. Is this true or false? You just need to click on true or click on false. All right, and the answer is false. You sometimes don't get early symptoms. Scoreboard, Papa Doc still leading. Come on, Professor Mackenzie, Nikki, and Fogel. You can do it. You can still do it. You're just about halfway. What is the main message of prostate cancer? All right, and we have 4 answers in. And we are counting 7, 6, 5, 4, 3, 2, 1. And the correct answer is green. Early detection saves life. That is the main message that we are saying here. And the scoreboard has Papa Doc still leading as we move to number 9. Which organization recently partnered with the health department to host a health screening fair in Westmoreland? Who was this organization? Was it Jamaica Cancer Society, Red Cross, Misty Blue Cancer Foundation, or National Health Fund? It was recently, just recently, and I know some men would have gone to get the screening. All right. Only 1 person got it correctly. And let's see who that person is. And it was ADM. I guess that's Adrian. You're moving up, Adrian. Very well. Very well. All right. So it was Misty Blue Foundation just last week, right there in Independence Park. All right. So this same organization had a theme. What was the theme for this health fair or the screening event? Was it check your prostate, save life, fight cancer together, men health first, or man up and give prostate cancer the finger, save your nuts? And the answer is man up and give prostate cancer the finger and save your nuts. All right, let me see who got it correct. And it was Papa Doc and Professor. All right, come on now. Let's see question number 11. What is the major barrier or stigma that prevents men from getting a digital rectal exam? And we have, is it that they fear needles? They don't have any time watching, they are watching football or doing something else, or the cost of the test is too much? Or is it that they just fear the discomfort about the finger insertion? Which I think is the correct answer. And we have all correct there with green, fear the discomfort about the finger insertion. Let's see the scoreboard, and Papa Doc leading, followed by Professor Mackenzie coming right up. Adrian, our ADM, you're still the same place. So let's see. Number 12. What alternative tests do some men prefer instead of the DRE or DRE? Is it the PSA blood test? Is it a MRI? Is it an ultrasound or CT scan? Which would they prefer or use instead? And we have 3 answers in. And the correct answer is red, the PSA blood test. Let's see who had the correct answer. And it was Papa Doc. Professor, you're having a good streak there. As we move to question number 13. Should be 13 there. What strategy was used to reduce the barrier of the stigma for the DRE? Call it DRE, I'm not medical. At the screening event, at the same screening event, they had a strategy that they use. So men would come in. It's only male doctors, only female doctors. Our doctors did the DREs virtually. All right. Nobody answered correctly. All right, so what they used was using female doctors. The men feel more comfortable when it was a woman doing it and not a male doctor. So that was the strategy they used. And of course, the men turn out. All right. So we're at the same place on the notice, on the leaders board, and we have one more question after this one. So let's see who will be the winner. What does it mean when the doctor says digital exam? Is he said he will send you an exam online? Will he administer a finger exam? Or will he post your results on Instagram? Or will he examine you using a computer? What does that mean when he tell you that? Men? All right. Okay. We have 3 correct answer here. Using the administration of the finger exam. And before we're moving up, Doc, you're on top still as we look at the last question. And this one says, what's the best way to make your wife or girlfriend happy during Prostate Awareness Month? Take her shopping, take her on a vacation. Why don't you cook dinner? Or is it you take yourself to the doctor for a checkup? Six, 5, 4, 3, 2, 1. All right. Yay, gentlemen. Thought you were going to take her shopping, you know. But yes, so you can be happy and she can be happy. Take yourself to the doctor for a checkup. So men, that's the message to you today, tonight. Take yourself to the doctor for a checkup. God bless you and do have a wonderful rest of the evening as we continue to learn together. God bless.
Thank you so much, Sister Delmarie. That was an awesome icebreaker. I hope we didn't go too much into our doctor's education session, but that will make it easier for you, docs. Don't you worry. The more we hear, the more we learn. And so that was very good for Delmarie. Thank you very much, Del. And tonight I have 2 people who are going to be giving me testimonials. And going to be very short, very, very short. And our special ad tonight is coming from Pastor Andrew Steele. And he is an international marketing director of the Zon Natural Limited. And he's going to tell us about a product that helps us not just to prevent prostate cancer, but to prevent several health issues. And I can tell you that I have benefited from it my own self. I know of people very close to me who have been doing much better since they are taking these products. And so I particularly asked him to tell us a little bit about it. He's not going to be long. He's not our guest speaker. He's just going to be doing an ad for me. And I want him to come on now. Pastor Andrew Steele, where are you? Could you just open and come on? You have 3 minutes. Dr. Thomas is getting ready now. So let's hear from you now, Andrew. I know he's traveling by car, so he might have a little challenge, but let's hear from him.
Hello, everybody.
Hello.
Hello. Can
Hello.
everybody hear me?
Yes, we're hearing you.
I'm going to be turning my cameras on.
Okay. I hope you're parked.
I am sitting down.
All right.
But good night, everybody.
Yes, good night.
And special greetings to you. I'm turning my camera on. So those online can actually see me, see the products as well. But it's an honor to be here. So to all the doctors and participants alike, greetings to you. I'm here to promote 2 products that are manufactured by Zon Naturals. It's a Jamaican company, and actually the plant that these products are manufactured from is a patented plant that was discovered here in Jamaica. In fact, the professor from Michigan University actually said that the possibility of finding this plant is 1 in a trillion. So here's our Zon T-Zan. It is a tea that is made from the plant. And the second product is our Zon 100 capsules. Just to say the efficacies are amazing. We've had over 18 universities that have studied this plant. And our Zon 100 capsules are actually approved by the Ministry of Health and Wellness. So for men with prostate issues, we recommend our products, and it is known to lower the PSA for men that's having high PSA scores. In fact, if you go online, you can actually search University of Northern Caribbean University. They did an enormous amount of studies and actually show the results from that. And just to say to you that our products are particularly effective against every gut and stomach issue. So you talk about GERD, acid reflux, you name it, bloating, ulcers, and even H. pylori. Our products are known to eliminate it from the stomach. Dr. Heyman in Maypen is doing an amazing clinical work with our products, and a lot of people are going to him. So for those who would like to call Dr. Heyman, you can do so. Tell him Andrew Steve told you to call him, and he will certainly update it because he's having amazing results. In fact, we're having 100% efficacy on different gut and stomach related issues. Finally, women with dysmenorrhea and all of that, our products will take care of that and help people with endometriosis and a whole lot more issues that including cancer. We have been treating so many people with breast cancer issues and other cancer related things. So that's it for me, but you can reach me at 876-495-4518. Otherwise, you can always go to Sister Nepaul, Sister Juliet Nepaul, and get my number. All right, thank you, everybody.
Thank you so much, Pastor Steele. Very enlightening. And to hear that it's coming straight out of Jamaica, this is something that is still understudied, but it has been going through a lot of studies. And to hear that the Ministry of Health has now passed it as something that is safe. And we said we have been getting results. So the Bible did tell us that the healing of the nation can be found in the trees, and this is where they went. So you can hear some more about it. As I tell you, I know of people who are getting amazing results, and so we are going to look at that a little more also. Thank you, Pastor Steele.
Thank you for having me.
All right. And right before we have our guest speaker, who is, I'm quite sure, is getting edgy now. I know doctors, every minute is very special for them. We're going to be having one of our own doctors, in-house doctor, Dr. Donette Bryan. She's going to be introducing the guest speaker and the moderator. Well, we all know the moderator, but she will just tell you about him, the guest speaker, and then Doctor will come on. They will both come on together and they will take it from here. So, Dr. Bride, your time to introduce the guest speaker for us at this time.
Our moderator, who is well known, our moderator for the rest of the night is going to be none other than our dear in-house doctor, Dr. Bishop Evan Nepaul, the president of Holiness Born Again Church.
Oh, you're freezing, Donna.
Consultant urologist with over 5 years of experience.
We didn't hear that. You were freezing.
Oh.
Okay, just start back with Dr. Thomas, please.
Okay, so Dr. Thomas is a consultant urologist with over 5 years of experience serving both the public and private health sectors across Jamaica. He's a graduate of the University of the West Indies, where he earned his Bachelor's of Medicine, Bachelor's of Surgery, as well as his Doctor of Medicine in Urology. Dr. Thomas has also trained internationally at leading institutions, including the University Health Network, Princess Margaret Cancer Center, and Toronto Western Hospital in Canada. His medical expertise spans stone management, male infertility, erectile dysfunction management, and urogenital malignancies, with a deep professional interest in uro-oncology, reconstructive urology, and endourology. So he comes with a lot of experience. In addition to his clinical practice at J. Thomas Urology and Cornwall Regional Hospitals, Dr. Thomas has distinguished himself as a leader and advocate for patient education.
Oops, freezing.
Medical as well. He's an active member of the Jamaica Urological Society, the American Urological Society, and the Caribbean Urological Association, among others. Charge of their health. This evening, he joins us to share his expertise and guidance on prostate cancer awareness, a message that is vital, timely, and potentially life-saving. We encourage everyone to listen attentively, engage with questions, and carry this important conversation forward by sharing the knowledge with your family, your colleagues, and your friends. Ladies and gentlemen, please welcome our guest speaker tonight, Dr. Jeremy Thomas, and our moderator, Dr. Evan Nepaul.
Okay, go ahead, Dr. Nepaul.
Okay, yes, good night, and thanks for having me. I am so excited tonight, mainly because I'm a man and I'm in the group that it's really a concerned group. And so why this topic tonight? Prostate cancer is the most common cancer among Jamaican men, and Jamaica has one of the highest prostate cancer mortality in the world. And that's really, saddened. And early detection can save lives which is good. But many men are fearful or reluctant to check. I was pleasantly surprised in the recent weekend or two to know when they had that at Independence Park and the various places in Westmoreland. There's so many men coming forth to have their cancer, the prostate checked. We must emphasize tonight the role of the family, as Donit has said, wives, daughters, sisters often encourage men to seek care. The family unit is key and in breaking this silence and fear. And so I must say kudos to Flame tonight for putting on this very, very special evening. Tonight, we should be able to know and understand the prostate. We will be able to understand the risk factors involved, certainly the symptoms to watch for. We have to also get a great awareness of prevention and control. And so we hope also that we'll have time to have an interactive session in which we can ask Doc some really certain question and on the way forward in our lives. So, ladies and gentlemen, we are out for a good treat tonight as we have this. By the way, I don't think Dr. Donnett had mentioned that a guest speaker tonight also practiced urology at the Royal Winchester Hospital here in Savanna La Mar, 10 Louis Street. We were so blessed to have had Professor Lawson Douglas all these years, and he went right up until I think he's above 90 years of age. Just last week, he traveled all the way from Kingston to look for us and to spend an afternoon with us. Well, he's retired, and his blessings has passed on to this young stalwart in the person of Dr. Jeremy Thomas. And so we're happy to have him at Royal also. And I guess Flame have to just pay me for that ad that I just put in. So, ladies and gentlemen, let us receive to open our knowledge on prostate cancer, what it is, prevention, risk factor, and all these things. Dr. Jeremy Thomas. Over to you, Doc.
Yes. Good night.
Good night.
All right. Let me just have my video up. Hopefully you're seeing me. So thanks for having me. Thanks for that amazing introduction. And I'm happy to be a part of the family here and to speak on this very important topic. So without much further ado, I will attempt to share my screen so that we can begin the presentation. You can just let me know if you're seeing.
Yes, we're good. We're good.
All right, great. All right, so tonight's topic will be, as mentioned before, on several occasions, that September is Prostate Cancer Awareness Month. And it is something that we believe over the years has been not spoken about enough, and certainly enough is not out there about it for such a significant health issue that affects our society. So I copied the heading that was put up on the poster. So protect the prostate, preserve the man. I think it's a very appropriate heading. So congrats on that. So without further ado, I'll begin. So I had a couple of icebreakers myself. I don't know if I'll get interaction maybe in the chat. But the first question is prostate cancer the most common cancer worldwide? And see if I can find a chat, see if anybody has answered. All right, so I'm seeing yes in men, no in, I'm assuming that's no in Jamaica. All right. Feel free. I think there are over 80 people here, so the answers can continue to come in. Okay, anyways, so no, it isn't. All right. It's actually lung cancer that's the commonest cancer worldwide. And in some cases, some would say skin cancer, but it's actually lung cancer. However, is prostate cancer the most common cancer in Jamaica? Not just in men, but in Jamaica overall. And I'm seeing yes, no, no, yes, no. All right, so I'm seeing a few answers. And again, somewhat of a trick question. The answer is actually yes, and it should be highlighted in a much bigger form. So it's actually more common than, or a more common cancer than breast cancer. And all the other cancers that have been spoken about in their respective months or on their respective months and year round. It's actually the commonest cancer. So I'll just go through the brief outline of what is cancer, the epidemiology behind prostate cancer, risk factors, screening, diagnosis, treatment, and outcomes. So to begin with, I'll start, it may seem a bit basic to some, but I'll tell you why, and this is just based on experience with what the prostate is. So the prostate, as was mentioned before, is an organ, a male organ. So every man has it for the most part. It's a part of the male reproductive system. Now, this picture depicts, basically if you were to cut through or looking from a gentleman, and you'll be able to see inside from the side view. So it's showing the prostate here that's sitting right below the bladder. So deep down in the pelvis. And right behind where we call the pelvic bone. You'll see the male organ here that's exposed on the outside, penis or the phallus, the scrotum, which would contain the testes. So the prostate is connected to those and it sits right below the bladder. So I always say it's like a door to the bladder which is responsible for storing urine. And of course, it sits right in front of the rectum. And this is the most distal part of the gastrointestinal tract, the anus, the last part through which stool passes. And it's kind of important because it will have implications for how we examine the prostate health, and how we diagnose prostate cancer. So here's a picture in a bit of color just to highlight the prostate. So as you can see, it sits right below the bladder. It actually forms the first part of the tube through which you pee. We call it the urethra, so we call it the prostatic urethra. Right here, it actually sits in a fixed space, almost like a plant in a flower pot. And the tube continues here, and urine comes out on the outside here, again, sitting in front of the rectum. So what are the functions of the prostate? So it's a walnut-sized organ, but I'd say in Jamaica it's a lime-sized shape organ. Its main function, or the most popular function, is that it plays a very important role in fertility. So it contributes about 30% of fluid, or 30% of the volume of semen. And it's very, very important for the nutrition of sperm. So it actually produces a number of proteolytic enzymes. The most popular one, which is very important for the purposes of prostate cancer, is called prostatic specific antigen, otherwise known as PSA. It also has several other important chemicals within it, zinc, citric acid, amongst others. And it, along with the seminal vesicles, which are two paired organs, I should say, which sit right behind the prostate, basically make up the majority of the fluid of semen. The prostate also, as I said, it sits right below the bladder. It forms a part of the internal sphincter complex. And let me break that down. It basically aids or plays a role in your ability to control your urine. Lastly, that fancy word right there, 5-alpha reductase. It basically also, amongst this enzyme, it possesses other enzymes, but this enzyme is particularly important in the male. Again, it's not only present in the prostate, but in prostate stromal cells, they produce quite a bit of it, and it converts testosterone, which some will know is the male hormone, responsible for a lot of your secondary male characteristics, the hair, the chest, the muscle mass, the bone mass. It actually converts it into a much more active form that actually carries out a lot of those roles, which is dihydrotestosterone. All right, so what is prostate cancer? So I'll break it down into two. I just spoke about what the prostate is, so I'll speak about what cancer is, right? So essentially, in the body, different organs are almost like different institutions. They go according to a program. There is, the CEO, then there are the various bodies, the assistant, the workers. And just so imagine a company that works and everybody plays their role and obeys their functions. But now imagine there's another company where there is no head and everybody does what they want. It's almost like a breakaway. I always compare it to cancer is like where you'd have within a community those who disobey the law. So they don't obey the law, the gunmen, the others. And as you know what that results in, it's a similar thing with cancer in terms of breaking it down. So you have in the body, you have genes, which are, present on what's called DNA, and these are responsible for controlling functions, where cells develop, when they develop. But of course, unfortunately, in cancer, this function is lost as a result of defects to these genes. And so unregulated growth, unregulated spread, whether directly or indirectly, happens when you have cancer occurring. And depending on which organ it arises from, then it is, named after the organ. So of course, in prostate cancers where you have these cells growing, they're unregulated. They may spread directly outside of the prostate. They may spread via the bloodstream. They may spread via other routes elsewhere in the body, and they can cause significant illness and, of course, unfortunately, death. To get into why it is that prostate cancer is particularly important and such a serious concern in Jamaica is that this slide is a bit ugly, but I'm hoping that you'll see it on your screens. In blue is mentioned the incidence of prostate cancer per 100,000, so the prevalence. And you might look at this and say, well, hold on, Australia has a way more significant problem than, well, look at where the Caribbean is here. Because Australia, 111 per 100,000, sorry, 111 per 100,000 men actually have prostate cancer, as opposed to in the Caribbean, it's about 79.8. But I want you to look carefully at the red columns here. And the highest red column here, which represents mortality, which is the number of men dying from prostate cancer, is actually highest in the Caribbean. And Jamaica is a part of that. All right. So we have the highest number of men per 100,000 in terms of percentages actually at risk of dying from prostate cancer, as opposed to regions around the world. So to get in a bit more detail, the incidence of prostate cancer in Jamaica is actually 78 per 100,000 men per year. I don't think I have it on this presentation, but I will tell you in 2020, when Globacon, which is the global observatory body, did their studies with regards to Jamaica, over 1,500 men were diagnosed with prostate cancer for that year, and this trend has certainly continued. Looking at this mortality here of 53 per 100,000, and I'll break it down into what it would mean for us in terms of figures, over 800 men. I think in the year 2020 was 844 men that actually passed from prostate cancer. You would have heard arguments about the homicide rate in Jamaica and the rates of deaths from other things. 844, that's a lot. It's actually more common again than breast cancer. And as you can see, to compare here with others, lung cancer, colon cancer, this is for men specifically. Breast cancer is a little behind it at 43.6 per 100,000. And then you go down the line, you see cervical cancer here. So again, the take-home message is prostate cancer is the most common cancer in Jamaica and the leading cause of cancer-related deaths. Now, we seek to explain why this is the case in the Caribbean and in Jamaica. And there are certain risk factors which I'll get into, and the epidemiology speaks to it, where it is unfortunate that men of African descent are at greater risk of getting prostate cancer. As you can see there, they're at 60% more, a greater likelihood then, or 6% more chance of them getting prostate cancer. Unfortunately, prostate cancer that actually develops in men of African descent is more aggressive at diagnosis, and they are 3 times more likely to actually die from this disease. So it's a significant problem in Jamaica and in the Caribbean. Now, unfortunately, a study was done, and again, this is back in 2020 or a bit earlier, Again, that speaks to the fear that Jamaican men have. You know, more than almost 100% of men had never had a prostate examination. And this is, of course, referring to men within the age group, which I'll get into. And there's various reasons given based on the questionnaires that were put out there for this study, you know, between inconvenience, ignorance, and fear. And of course, you know, I think overall, really and truly, it boils down to ignorance. And just in general, attitudes and values towards healthcare amongst men. So we seek to change this along with Jamaica Cancer Society. So I'm going to get into the risk factors next. So these, despite what you may hear around, are the established risk factors. And I want you to take a careful look at this. Age, race, and family history. None of these here mention lifestyle, as much as lifestyle plays a very important role in prostate cancer, and I'll explain later why. But the key thing to note about all of these factors is that getting older is a blessing. It's a gift. But unfortunately, as you get older, you're at an increased risk of getting prostate cancer and other illnesses. That's not something that you can modify. Even if you dye your hair, even if you go to the plastic surgeon, even if you get whatever it is that they'll offer. Race. Unfortunately, in Jamaica, we do have some people who don't identify with their color, and so they'll bleach. But even if you change your color, your race, that same genetic makeup, that same DNA that contains your genes is going to remain the same. Again, men of African descent, right? Unfortunately, you can't modify that. And family history. Again, even if you don't like your family, unfortunately, you still share some of the same genes. You still may share some of those defective genes. And so if you have a first-degree relative that has prostate cancer, so a father, an uncle, maybe even a cousin, a grandfather, if you have two, and I'll also say in terms of family history and as it relates to genes, if you even have female family members who have breast cancer, ovarian cancer, if there's a history of pancreatic cancer, essentially there are several genes that are associated with hereditary prostate cancer. For those who may know about breast cancer a bit more, the BRCA1 and BRCA2 genes, which are commonly spoken about when we speak about breast cancer, actually are present and pose an increased risk for developing prostate cancer. And there are several others. There's actually currently several studies that are seeking to map out all the genes that are associated with the risk of prostate cancer. And the hope is that in time to come, we may be able to detect even earlier or know those who are at risk based on linear genetic mapping and so on. But we're not there just yet. But the important take home from this slide is that the established risk factors are non-modifiable. So the thing with prostate cancer is that it is not preventable, but there is definitely an advantage to detecting it early, as there's almost 100% cure if it is caught when it is confined to the prostate. Now, age, as I mentioned before, the older you get, the greater the risk. As you'll see, a man in his 40s, there's a risk of 1 in 500. But when you look at a man who is now in his 50s, that risk has gone up by 10 times, a factor of 10 times, right? So from 1 in 500 to 1 in 50. And as you can see in his 60s, it goes to 1 in 14, in the 70s, 1 in 9. And the older you get is the higher the risk of prostate cancer. Family history, as I mentioned before, the average risk is about 8% in the population. You'll see some figures saying 1 in 8 men in Jamaica will develop prostate cancer. It might actually be a lower number than that. But you'll see that your risk factor actually almost doubles if you have a father or brother, and it almost triples, relatively speaking, if you have 2 relatives. And especially if those relatives would have been diagnosed at a younger age, it puts you at an even greater risk. Now, just to speak about some of the other risk factors or other associated factors with prostate cancer, and just to clear up some of the, I would say, misnomers, some of the slightly incorrect things that might be out there. There are some things that have some associations with a reduction in prostate cancer, definitely proven. So that first thing mentioned there, finasteride, is actually a drug that's used to shrink the prostate, and that's for men with a non-cancerous enlargement of the prostate gland. Finasteride and another one called dutasteride. In Jamaica, you'll hear of Duodat, and there are other names for these drugs. Duodat, Avodart, Fincar, amongst others. Some of the men here who may take it may know those. Those are actually associated with a reduced risk of getting prostate cancer. They're not given for that purpose, so they're given to shrink the prostate. I must point out, though, that the studies that looked at these drugs actually show a slightly increased risk of more aggressive cancer when it develops. But we don't think that that risk is significant, but it's something that definitely men should be aware of when they're put on these medications. Interestingly enough, metformin, statins, and some of those other things mentioned there are actually associated with a decreased risk of prostate cancer. So patients who are actually diabetic and are on certain medications is actually associated with a lower risk of getting prostate cancer. Must say that there should be some caution exercise. Vitamin E, there's actually a recent study that suggests that could be a slightly increased risk of prostate cancer associated with vitamin E, as good as it may sound there. But in general, it's thought that vitamins in general are associated with decreasing the risk of prostate cancer. What I'll say is that a lot of these vitamins have been studied extensively. And sorry, I don't want to break or burst any bubble here of anything that has been promoted per se. And I won't speak in detail of that, but I will say that a lot of major studies have not shown significant benefits. Maybe things have happened in recent times, but I'll tell you that there are big studies done on selenium, same vitamin E, amongst others, and it didn't really show a decreased risk of prostate cancer. Ginger and pimento, based on their anti-inflammatory properties, we think in general. Coffee, again, it has been one that's controversial. I think the most recent thing now is that there is a decreased risk with prostate cancer. Nuts, again, for some of the healthy oils that they possess, and some of the anti-inflammatory properties are thought to, have some sort of decreased risk of developing prostate cancer. But I would exercise caution in terms of saying that they prevent prostate cancer, and they play a significant role in reducing the risk of prostate cancer, especially if you have a family history, you're of African descent. The message I actually want that should be taken home from this is screening for prostate cancer at the end of the day, and I'll get into that. Guinea hen weed, again, in Jamaica, we're into our herbs, we're into our alternative medicine. Again, it is something that is widely used, it's thought to have a lot of anti-inflammatory properties. I have no issue with it. Phytochemicals, fruits, vegetables, grains are all good things. We will talk about the whole Mediterranean diet as it relates to prostate health. Certainly a very good thing that I would encourage. Again, cannot prevent prostate cancer. Smoking, you'll see that question mark there, and that's because, again, some studies would suggest there's an increased association between smoking and prostate cancer. Others would suggest the opposite. What I will say is that smoking definitely worsens the outcome once you're diagnosed with prostate cancer. It's definitely proven that in terms of how you respond to treatment, the type of prostate cancer you get, and even when you get recurrence, your risk of recurrence and how well you do from it is actually worsened by smoking. So we certainly advise against smoking if there's anybody here who smokes. Again, in terms of lifestyle, though it can't prevent it, we definitely promote exercise and physical activity, decrease intake of your processed meats and fat intake and dairy products. Obesity and metabolic syndrome, which is related to obesity, is definitely associated with an increased risk of more aggressive prostate cancer once it develops, and also a worse outcome from the treatment, the different treatment options for prostate cancer. Alcohol is kind of one of those that sits on the fence, but based on all the other evils of alcohol, we definitely advise against any heavy usage of it. Now you'll see a little map beside ejaculation, and this one is of particular interest and a bit of controversy to those who may not know. So hopefully this is not a bit too explicit for the audience here, but interestingly enough, there was a major study coming out of Harvard where they looked at men who and their risk for prostate cancer, and they looked at the number of times they'd ejaculate. And it was actually noted that men who ejaculated 21 times or more per month, there's actually a significantly decreased risk of contracting prostate cancer. This is in their 20s and 30s and 30s and 40s versus men who only ejaculated 4 to 7 times per month. There's about a 30%, up to a 30% risk reduction in developing prostate cancer. So always bring some laughter to the audience. It's not just in isolation. No, we think there are some confounding factors for that. But you may come across some articles that preach against ejaculation and suggest that you should retain, but we don't have any proof that that's actually healthy or that helps. We definitely obviously always practice safe practices, and nothing that's unprotected or anything like that. But certainly with regards to prostate cancer, as far as you're aware, this study out of Harvard, which involved almost 30,000 men, showed this. And there's actually another study in Australia that looked at, I think it came down to 4.6 to 7 times per month versus 4.6 to 7 times per week versus 2 to 3 times per week. Again, showing a similar risk reduction of anywhere between 20 to 30% in terms of your risk for prostate cancer later in life. In Jamaica, again, we speak of all these other things, bad luck theory, don't want to get into those things. Again, we think that, genetic and environmental factors do play a role, more so genetic than environmental factors. But, in general, a healthy lifestyle definitely helps with not just reducing the risk of prostate cancer or how well you do if you have prostate cancer, but certainly a whole host of other conditions, including cancers. All right, so this brings me on to where we want to get to. Screening. And before I even get to screening, probably just a bit of backup in terms of epidemiology again. In terms of overall for men, prostate cancer probably makes up almost 50% of cancers in Jamaica for men, probably about 42%. Overall, when we put men and women together, it's about 21% versus 16% for breast cancer. All right. So prostate cancer screening. We believe that the tests that are available, or the tests that are available, it should be simple, readily accessible, affordable, and of course the availability of treatment. And of course, the important thing with effectiveness for screening is that we detect it before it becomes symptomatic, and we are able to change the course of it. So screening for prostate cancer involves two things. A simple blood test, which is just a little stick to the arm or wherever to get a bit of blood. It will test for prostatic specific antigen. As I mentioned before, this is a protein that's produced by the prostate. It's actually in higher levels in the bloodstream in men who have prostate cancer. So the magic number is 4. So if you've done a blood test recently and you see PSA, anything that's over 4 is abnormal. Even if your doctor said to you that's fine, please seek a second opinion. It is not normal. Now, why I say this and I stress this is that unfortunately, I have seen a couple of cases or quite a few cases where a PSA will come back and it's 5, it's 4 point something, it's 6. And the person would be advised by their family doctor that this is not too bad, so you can get yourself checked in a year or 2. And unfortunately, what will happen is that they'll come back sometimes in a year, sometimes in 2. PSA has now shot up to 50. You do the biopsy afterwards, and it is that they have prostate cancer, and it's prostate cancer that's no longer curative. It's advanced disease, right? Now, yes, the lower the PSA value, even if it's abnormal, the less likely prostate cancer is to be there. And we look at things like looking at the size of the prostate to say whether or not the amount of PSA that is there, is because of how big the prostate is. But I would say just to simplify it, if your PSA is over 4, get a second opinion, and it is very likely that you may need a biopsy for the prostate, which will get tissue from the prostate and allows us to test for prostate cancer. The second thing doing screening, probably got a bit ahead of myself, is the digital rectal exam. As I saw in the questionnaire at the start, yes, a lot of men are afraid. Some are the discomfort, but I think a lot of men is because of the stigma that's associated with sexuality. But I always assure men that, listen, this test is a few seconds. it is nothing that's going to change your sexuality. Whatever your sexuality was before you got the exam is what it's going to be afterwards, right? It's a few seconds. I like to say that, listen, if there is a problem with your muffler, there's no way me looking at the roof of your car on the lights there can help me diagnose what's wrong with the muffler. Now, there may be other things related, but where your prostate is, based on the picture I showed earlier, is right up in front of the last part of the rectum, right, which is where you pass your stool. And in fact, where most prostate cancers develop is right in that area there at the back of the prostate. So we're actually able to feel relatively early prostate cancer if it starts to stick outside of the prostate. And that's why that exam is combined with the blood tests. As you see here, the blood test for the prostate, PSA, is not the perfect test. A very good start. So let me hasten to say, even if you're afraid of the exam, at least start with the blood tests. But it's not the perfect test because there are other things that can cause this to be high. Ejaculation, infection, and enlargement of the prostate, which sometimes creates a bit of confusion because this is also something that is common as men or becomes more common as men get older. And sometimes what men, or I would say more commonly what men represent with to their doctors as a concern are actually signs of an enlarged prostate, which is where your urine starts to slow down, you start going more frequently, and there are different things mentioned about how you pass your urine. Those things are more commonly associated with an enlarged prostate as opposed to prostate cancer. I want to highlight here at the bottom that ultrasound does not play a role. A lot of times, men will come into the practice and they will say, Doc, I did an ultrasound, so I don't need the exam, I probably don't need the blood test. An ultrasound, as good as it may sound and as good as it may try to predict what your PSA should be, or it will say that there is some irregular area and recommends a prostate biopsy, it really does not play a role, regardless of what that report says. It's kind of 50-50 like flipping a coin. So it neither tells me whether or not you should have a biopsy or you're fine and you come back again next year. It really comes down to those two tests, the examination and the blood test. And we think it should be done once per year. Just quickly, it's relatively new. It was introduced in 1989. Unfortunately, the study that was done in Kingston shows that still 50% of men diagnosed with prostate cancer are diagnosed on the basis of symptoms and signs. And it's going to bring me to what the signs and symptoms are of prostate cancer. Before I get to that though, just to interject, in Jamaica, because we are a high-risk population, I want you to look at the last slide here, or the last part of the slide here, is that we believe that prostate cancer screening should start at age 40, and it should be on a yearly basis. This year, I should correct a bit. We used to say until age 70, but we actually would have increased that. And it's really, we look at a 10-year life expectancy because all the studies would have shown that there's benefit to screening for prostate cancer once you think that there is a 10-year life expectancy. So a fit, healthy 75-year-old male that is going to the farm, that is carrying out his daily activity, if there's any reason for concern and he comes for his checkup, it is reasonable for him to get a PSA, because if it is abnormal, then there may be some benefit to diagnosing prostate cancer and treating him. It varies around the different regions, but you have to remember the demography is different from what's in Jamaica, where up to 91% of our men are of African descent. All right, briefly here, as you can see, where prostate cancer usually develops is the rectal exam. It's just the tip of the finger. It's right there at the edge. The prostate sits right in front of the rectum. Where 70 to 80% of prostate cancers unfortunately develop is where we call the peripheral zone, which is on the back end of the prostate, right in front of the rectum. So as you can imagine, if cancer develops and it starts to grow through this capsule here, then it may feel abnormal on examination and not smooth. And that's what we check for when we do the examination. Now, I want you to look at these 7 symptoms mentioned here, and I want you to tell me what is wrong with this poster. You can all answer it amongst yourselves or silently. So you'll see 7 significant signs here of prostate cancer. So you'll see a weak or interrupted stream, sudden urge to urinate or other urinary symptoms, trouble to start passing your urine or to empty your bladder completely, painful or burning on when you pass your urine, blood in the urine or blood in the semen, pain to the back, hips, or pelvis, and breathlessness, tiredness, dizziness, and symptoms of anemia, low blood count. And that's the problem. And it was mentioned earlier. Early prostate cancer, which is almost 100% curable, has absolutely no signs or symptoms. So the patient will come in and says, Doc, I feel fine. I'm running around. I am carrying out my usual activities. I'm lifting up cement. I'm doing whatever. Don't get carried away by that. You need to be screened for prostate cancer. In fact, without getting too personal, I think only recently there's a patient from the West End who had a PSA, I think, of 5 January, felt quite fine, was advised to get a biopsy, delayed by just 7 to 8 months, and usually nothing happens, but then came back with some difficulty passing urine and some other symptoms, some pain down in the pelvis. The repeat blood test showed a PSA of over 50. He did an MRI and it basically showed stage 4 prostate cancer. Now, I'm not trying to start any sort of fear mongering here. That's not the typical case because a lot of people, 5 last year, probably 5 this year or 6 this year. And even if it is that we diagnose prostate cancer a year later, the presumption is that we still would have caught it at the same stage. And so there's no disadvantage to catching it a year later. But I want to highlight that there are those cases whereby you're not going to be so fortunate. So, take-home message, apart from prostate cancer being the most common cancer in Jamaica, is that we're a high-risk population based on those risk factors I mentioned, age, race, and genetics. Screening starts at age 40. It should be done on a yearly basis up until you're in your 70s. Now, the next step is that if either of those investigations are abnormal, the next step we usually take is to do a biopsy. Biopsy is a bit of an uncomfortable test. It is where we get tissue via the back passage from the prostate using an ultrasound machine to get tissue from the prostate, and that's sent to the lab for testing. Usually we get the results in a few weeks and it will tell us whether or not there is prostate cancer. Now, it is important to note that even if you've had a biopsy before, unfortunately, a biopsy, we try to take a fair representation of the prostate gland, but we can still miss the prostate cancer there. So even if you get a negative biopsy and we all rejoice, it still means that you should still be just as steadfast with going on a yearly basis to do your blood tests, to get your examination. In more recent times, we actually now starting to use MRIs as a part of screening prostate or biopsy naive men who have not had biopsies before. Something like an MRI certainly helps, not an ultrasound, but it still has not taken away from doing that blood test and the examination. Now, unfortunately, if the unfortunate diagnosis of prostate cancer is made, the 3 things that what we are concerned about is really staging it, because that then has implications for how well you'll do in terms of treatment. So I'll just quickly go through. Just broadly speaking, what we want to know is if it's confined within the prostate, in which case it is curable. If it is just outside of the prostate, in which case it may be still curable, but you may have to use multiple different methods to treat it. And then unfortunately, if it has spread to other organs, where we say stage 4 disease, it's not curable. But the good thing with prostate cancer is that we actually, and in recent times, we now have more and more medication on board that can actually control it in some cases for probably up to 20 years. Not everyone is going to be as fortunate, but we're pleased to say that prostate cancer is not a death sentence anymore. Quickly, I don't think we'll need to know this is staging our prostate cancer, so we add our investigations here, whether it's a CT and MRI, along with a bone scan to say where it is, if it's just in the prostate or if it's outside of the prostate, and then that will determine how we treat it. Now, as a urologist, how we treat it if it is within the prostate is via surgery, and that's removing the prostate gland. It's called a radical prostatectomy. most urologists in Jamaica will do this via an open technique, what we call a retropubic radical prostatectomy. So a cut is basically made, Dr. Nepaul will tell you, it's a well, for me, it's a C-section type of cut. So it's a cut right at the lower part of the abdomen, but some will go via the midline. So, you know, just a little below the navel or the umbilicus and going down towards the pelvic bone. We get access to the prostate below the bladder when we separate it from all its surrounding structures, take great care to separate it from the rectum behind it, and then we reattach the bladder to the tube through which you pass your urine. And that's called a radical prostatectomy. And we usually remove some of the lymph nodes, or what Jamaicans would call wax and canal, some of the first places that we think the prostate cancer can spread to. We usually remove that, but it's more so to enable us to accurately stage the prostate cancer, and so we know how to treat you after the prostate has been removed, along with those lymph nodes. The other major arm, which can also provide cure for prostate cancer, is radiation therapy, and that's done by our colleagues, the radiation oncologists. There is no cutting in that. So for men who are not fit for surgery for whatever reason, or they would have had conversations and they look at the pros and the cons of both, and they've decided now that they want to do radiation, it's also not a bad option. Though I'm going to be biased and say that I think that surgery for prostate cancer that's confined to the prostate certainly is advantageous and still does not, it still allows you to have additional treatment if you need in the form of radiation and so on. If you need it at the end of the day, if you know there's evidence of any recurrence or any residual disease. But radiation, usually combined with what we'd call hormonal therapy, which is where we manipulate the hormonal axis within the man to stop the production of testosterone, which is what we think most prostate cancers are sensitive to, is the other option. So it's surgery to remove the prostate on one hand, which we call a radical prostatectomy, versus radiation treatment, which is combined with hormonal therapy in terms of cure for prostate cancer. So I kind of overshot what I was putting on the slides, and I spoke about it. I said most surgeons do it via open approach. We do have a surgeon in Jamaica who does laparoscopic surgery. Most first world countries, though, are looking at robotic assisted laparoscopic prostatectomies. They call it RALP. Laparoscopic surgery is not so common in practice, but it is an option. It does offer minimal invasive. And as I said, there is one surgeon who does that in Jamaica, but all the other surgeons, I think, as far as I'm aware, we do via an open approach. And we believe in terms of your outcomes, in terms of recurrence or cure rates, are not inferior to the robotic assisted or the laparoscopic. I think where you may see differences is in terms of blood loss. But in terms of other outcomes or other complications or side effects that may be associated with surgery, we don't think that open surgery is, or certain studies have not suggested that it is inferior to the other methods, right? Active surveillance there is pretty much for a very carefully selected subset of men where we think the prostate cancer is so low risk in terms of how aggressive it is, and its volume is so low that we can actually closely follow them without putting them or exposing them to treatment. But I must must warn or that caution should be exercised, because the nature of prostate cancer is that it is multifocal, meaning that when you find it in one part of the prostate, you may have missed another part of the prostate. As I said, biopsies can miss up to 30% of cancers. And even though we'll use things like an MRI that can highlight where else in the prostate you may have prostate cancer, you could diagnose what is called a very low risk prostate cancer in one part of the prostate, but you're missing a more aggressive part in another part of the prostate. So even though this is mentioned here, I must say that caution should be exercised. Again, I don't want to confuse the audience. The long and short of it is that to cure prostate cancer, there is surgery, there is radiation therapy. There are complications, unfortunately, and again, I think this is where a lot of men shy away from the diagnosis, because erectile dysfunction is a real concern. Probably up to 40% of men, they may have some changes in how their erections are afterwards. Fortunately, there are a whole host of other things that can be done to counteract this. Some are not so effective. As I mentioned before, one of the roles of the prostate is in terms of controlling your urine. And so Fortunately here, way less men will suffer this complication, but probably up to 10% of men at 12 months will have some amount of leaking post-surgery. Again, thankfully, there are things that we can do. So there's an artificial urethral sphincter that can be placed. It's a device that allows the man to control when he pees. So there are things to counteract or to treat the potential side effects or complications from surgery. In a man who has locally advanced disease, they may require, as I said, multimodal therapy, which is radiation and hormonal treatment. For unfortunately, which up to 50% of Jamaican men present with, we do have to then look at hormonal therapy. I would have mentioned before, that is whereby we have different methods to stop the production of testosterone, and we found other ways to stop the progression of prostate cancer, and they've actually been pretty effective. So between the injections and tablets, this is what we call hormonal therapy. And basically these just are different ways of us stopping testosterone and other precursor hormones, which will stimulate the growth of the prostate and by extension, the growth of prostate cancer. What was actually done, not so commonly done now, some older men may actually relate to this, and this was actually started in Africa. As I mentioned, testosterone, which is primarily produced by your testes or your balls, was actually done in Africa, especially in a lot of poor areas or areas where there was not access to first-line healthcare, medication, and so on. It was surgical castration. And it's actually a quite effective method. If you talk to Professor Douglas, he'll tell you that this would have been done for quite a few men who would live far. They don't have good access to healthcare. It's going to take them several buses to get to the hospital. You may not have a urology center close by. And so actually, once you've confirmed the diagnosis of prostate cancer, one good way of controlling prostate cancer for a long time was actually removing the testes. It sounds gory, and for that reason, we've moved away. And what hormonal therapy actually is just a very fancy way of actually medically castrating the patient who is affected with prostate cancer, because what we're doing is stopping the function of the testes, which is producing testosterone. All right, unfortunately for those men who then can become resistant to that because the cancer can find other ways to grow. As I said, it's an unruly growth. Just imagine that breakaway faction within that community, those gunmen, they don't obey the laws and so on. You may have to get to chemotherapy. One of the first places that prostate cancer can spread to is your bones, which is why we do a bone scan early out when we're trying to screen for prostate cancer. So there are things that we give to protect the bones and to and especially when we're stopping the production of testosterone, it can actually weaken the bones. So again, we take great care to protect bone and prevent early bone fractures. All right. The follow-up is usually pretty intensive early. It's every 3 months. Again, prognosis, as with other cancers, depends on how aggressive the cancer is. So there's something called the Gleason score, and the higher that number is, the more aggressive it is. And of course, the patient's comorbidities, if do they have other illnesses that are uncontrolled. And even in the treatment of prostate cancer, it does affect other illnesses and how you do with those. So those are things that we look at. Sad to say, I will say that alternative therapy, there is really not any strong medical evidence that these work for prostate cancer. And so I'm going to, again, ask you to exercise caution as much as you may hear about wonder drugs. I'm just going to tell you from my perspective, and I may lose some fans here for this, but I will tell you, even in recent times, I remember immunogizer being promoted. And what we found is that a lot of men and women, breast cancer, prostate cancer, other cancers, would disappear from the hospital. Why? They're on immunogizer, they feel better. And unfortunately, what was not mentioned in the advertisement is that these men and women were turning up years later with very advanced disease and dying from it. Whereas if they were going according to standard of care and what we know that works, they probably would have been still alive. In some cases, they probably would have been cured. So just asking you to exercise caution. I'm not saying that some of these things can't be taken. I'm certainly not against guinea hen weed being taken and some of the other herbal remedies. But what I would stress is that you still consult with your doctor. You still follow what we call standardized guidelines for treatment and the whole screening protocol, and that puts you in the best state. to do well. All right. Now, the topic really was, I mentioned all the evils of prostate cancer, the risks that it poses, and why we should get screened at age 40 onwards, and how aggressive we should be with screening and what screening involves. But you may ask, what are some tips for keeping a healthy prostate? I would have mentioned some earlier too, looking at lifestyle, which includes diet, exercise, and so on. And what has actually been found is a Mediterranean diet, so that's rich in a variety of fresh fruits and vegetables. So that which is, rich in whole grains, legumes, healthy oils, moderate amounts of seafood, low amounts of dairy products, and red meat, forgive my pronunciation, is actually thought to be wholesome, in particularly men who practice this Mediterranean diet and in the Mediterranean region are particularly found to have a very low incidence of prostate cancer. Again, I hasten a bit of caution because it may also be race related, right? But I will tell you that a few studies would note that men who are moved from that area and placed into the West and then adapted a Western diet, the fried foods and all of that, their risk for prostate cancer actually increased. The relative risk for prostate cancer actually increased to that of the men that were around them. So, it then, brought us to thinking that maybe it's not just genetics alone, but diet does play a role, right? However, the recognized risk factors that have been proven beyond a shadow of a doubt is still age, race, and genetics. But I want to stress that diet overall for your healthy lifestyle, for other diseases, and even if unfortunately you get prostate cancer, how well you'll do from prostate cancer, diet and exercise certainly good. Vitamin E supplements, believe it or not, there's a study that actually showed an increased risk of aggressive prostate cancer with vitamin E. There are some other confounding factors, but I just want to urge caution with some of the supplements and the vitamins that are mentioned. When I mentioned get some sun here, this was actually coming from Harvard University, where it's, of course, speaking to a Caucasian population and a population that would not be as exposed to the sun as we are in our lovely tropical climate within Jamaica and across the Caribbean. But the take-home message for a healthy prostate is to get screened. All right, so in summary, what I want to take home message should be is that men should start screening for prostate cancer at age 40. It involves a simple blood test and an examination. Please remember that early prostate cancer, there are no signs or symptoms. Just to note why we advocate for early prostate cancer screening is that it is more aggressive in Black men and in those with a positive family history. Cancer survival is more likely the survival from prostate cancer is more likely if it's detected early. In fact, I would say it approaches 100%, right? And that's proven. So if we catch it when it's confined within the prostate, you're completely curable. When it's outside of the prostate, it's not curable. The good thing, though, for prostate cancer at the end of the day, though, is that there's treatment available for all stages of prostate cancer, so all hope is not lost. I think I've probably bored you along with my voice and the hiccups along the presentation. So at this point in time, I'm wrapping up the presentation, and I am happy to answer any questions or, any comments that you may have. So I'll hand back over to the moderator, Dr. Nepaul.
Yes, sir. Yes. This has been a very, very enlightening and man, it's sort of really mouthful and headful and every aspect of it. It was a very, very good presentation, Doc.
Yes, thank you. You're welcome.
Yeah, it was well presented, well researched, and very timely. And we really appreciate you, Doc, taking time out to really, come by and it really was. I'm overwhelmed with the wealth of knowledge, and not just that, the way in which you presented it. I think it was quite clear and very transparent, clarity. So we have a few little. We have some questions here.
Sure.
Well, first of all, I see someone is asking about a copy of the presentation. Just to let you know also that it's on YouTube, and I think it's the HBAC SAV. It will be on YouTube, so you can revise it on that. I'm not too sure if your notes will be available to them, Doc.
Okay,
But
yeah, I'm happy to share it. Yeah,
happy to
if they
share
are.
it. Okay, okay. So I guess they will get in touch with those in charge of Fame
Sure.
to get a copy of it. But it can I have to go through this again on YouTube. A few questions up in. Someone was asking. First of all, we noticed on the form, Doc, there's a PSA F/T. Is that free and total?
Right, it's free and
I think,
total.
and I
Yes,
think I learned a little about the freebie. You tell me a little more about that.
sure. So I'll tell you about that. So, all right. So this is getting into a bit of detail though. So I hope I won't lose anybody. So
Well,
PSA,
you have a gift of keeping it simple.
all right, no problem. So I'll try my best. So as I mentioned before, PSA, which stands for prostatic specific antigen, it's a little protein. It's actually an enzyme that is produced by each prostate cell. Now, a small amount of it is released into the bloodstream, and that's why we say the normal value is between 0 and 4. Now, with prostate cancer, the prostate actually sits in what is called a basement membrane, or it's surrounded by a basal layer, separate from the rest of the body, which is why only a small amount of it escapes into the bloodstream. With prostate cancer, though, per cell that is malignant, that layer is actually destroyed. And so, interestingly enough, although prostate cancer cells produce less PSA, because that layer is lost, more PSA actually leaks into the bloodstream and can get into the bloodstream, which is why PSA goes up or it goes higher. Now, PSA is a protein, so it goes through several processes. When it is fully formed and not partially formed, it can exist by itself as free PSA. When it is partially processed, for it to exist in the bloodstream, or what it tends to do is that it binds to other proteins. So, in a gentleman who has prostate cancer, PSA, you'll have, even if when you have higher levels of PSA within the bloodstream, you're going to find a lower ratio of free, which is fully formed, properly formed PSA, to the overall total PSA. And so we actually use it for some men when we're trying to determine if they are at increased risk for prostate cancer. We look at their free to total ratio. And we actually want a free to total ratio of greater than 25%. That for us indicates that there's a decreased risk of prostate cancer. But this is only a certain subset of men where their PSA is elevated, but it's not so high also. So it's between PSAs of between 4 and 10. Where you think there's probably not an increased risk of prostate cancer. It's that kind of gray area. Let's say they may have had a biopsy before, PSA was 5 before. You can look at what we call PSA adjuncts. So that free to total is actually quite important, but only for a specific subset of men, where the PSAs are 4 to 10. And if there is some dilemma or some sort of hesitation or some question as to whether or not, do we go ahead and get a biopsy? Do we go ahead and do further investigations to help get that diagnosis of a benign prostate, a prostate that's not cancerous, of course, more importantly, if there's cancer there, to detect it early.
Okay. So yeah, as you said at the beginning, I think this is more for you guys, more the expert after we have gone through the screen. Okay. We have a few other questions here. See, Carol, my good friend Carol Bihari, Nurse Bihari, had a few questions. I think I'm gonna leave her a question because she's gonna come in to kind of wrap up and to
Not
answer.
a problem.
Yeah, but there's about, let me see now, another person had asked, even though it was mentioned, maybe you could just emphasize. I think Shernet was asking whether the blood test or the digital screen is more accurate.
Oh, it's a good question.
Yeah, yes.
Good question. So the blood test is actually more accurate, I would say. But what we have done is we try to combine both the blood test and the examination to increase sensitivity and specificity. And even with those two combined, it's not 100% perfect. But yes, the blood test, so which is why I'd encourage that even if you're just going to start with the blood test, it's still a good starting point in terms of screening for prostate cancer. But the pickup rate increases when you combine both.
Right, combination. So
Correct.
both DR and also The blood test. That's what
Correct.
the take-home blood.
Yes.
That's
So
a
the
very good
recommendation.
question. Very good question. Another good question that is asked here, which you may think that it is just an obvious thing. Someone asked, when DRE is done, what is the doctor really checking for?
Okay, no problem. All right. And it's a very good question because
Very good question.
it's what has caused a lot of controversy. You know, people take it the wrong way. It's invasive, you know, it can be deemed as dehumanizing, humiliating, and so on, you know, amongst other things. So the thing is, as I mentioned before, and I don't know if you've seen the diagram, and maybe I can try and go back to the diagram, is that the prostate sits right in front of the last part of, so let me just see if I can get the picture here. Right there. So where the prostate sits is right in front of the rectum, which is the last part through which your stool will pass before it comes outside. So we know it sits at the front right there. Now, I also saw another question, I think, from Nurse Bihari about what are you checking for when you check the DRE. Now, as you look at this picture here, right, the prostate cancer, it's unregulated, unruly. It actually grows and protrudes out of the prostate. So what we actually look for is if you can feel your knuckles, anything that's hard and irregular, when we examine the prostate, is a red flag for us in terms of is there cancer, which could still be within the prostate, but it's certainly pushing on that capsule that the prostate is contained within. And obviously what we don't want it to do is break through that capsule and then extend into surrounding tissue. And in bad cases, it actually extends into the rectum and it can mimic what looks like a rectal cancer, right? And it's only on biopsy that we can determine that it's actually prostate versus rectum. All right, so what we're examining for is any abnormality with the prostate. We expect the prostate to actually feel like you'll see here, what we call my thenar eminence, the soft part here just below my thumb. But if it feels like the knuckles here, that's what we actually examine for. That's irregular for us. That's a red flag for us. Then we start looking more closely at your PSA, and you know, it may indicate you need to have a biopsy done.
Yes. Hello?
Yes. Yeah, man, I'm here.
I'm not too sure. Okay. Right. Yeah, that's a very good. There's another very important question here, Doc.
Sure.
Can any general, I think this is coming from Chaplain, can any general practitioner perform the PSA test, or is it a specialist? I would more add on to that question. Can any general practitioner do a DRE? So I'm going to add to that question. Huh?
Yeah, good question. So I would say yes, you know, the blood test is done at any lab, you know, any standardized lab. So any doctor, family doctor, general practitioner can order it. Or any specialist that you go to, if you've expressed an interest in being screened for prostate cancer, you know, the doctor cannot order it for you. It's just to tick it off on the paper. The examination, I would say, you know, any family doctor, any general practitioner should be able to, you know, but what you will find, it all comes down to, again, experience and knowing what you're looking for. So unfortunately, you'll find that some, and, you know, just based on inexperience, may not necessarily be comfortable with what they may find or they may be missing. And I mean, I would say, but this would be to the family doctor or general practitioner. If there's any question or there is any concern, then, you know, you pass them on to somebody who probably has a bit more experience. But any family doctor should be able to screen you for prostate cancer. Certainly, you know, as you would know, there aren't enough urologists in Jamaica to screen the population of men for prostate cancer. So it's the family doctors and general practitioners play a very, very important role in screening for prostate cancer.
Okay. Thank you very much, Doc. Yes, that's a good way to.
Sure.
So we are gonna ask before I close off. I don't know. I see Carol is now back. I know she was on the road. So Nurse Bihari, you have anything to add as such? Any question?
Yes, Doc. Thanks.
Right.
Thank you. Thank you so much, Dr. Thomas, for your presentation. You were going to say something else, Dr. Nepaul?
Right. So I'm going to say now, since, you know, he's going to out of my territory, I just want to let you know, though, that I do not go into the rectum that often, except when I close the episiotomy or do a vaginal surgery. I go to the rectum to make sure there's no, no connection.
yes,
So I just
for
want to let
sure.
people know. So don't come
Yes.
to me for a DRE, you know.
Okay, fair enough.
But
You know, I was going to say that, but
you
not to
know,
step on any toes. No, that's actually quite good.
right.
know,
The
I
other
mean,
thing now is that most
yeah.
general practitioners that I know
Mhm,
who are practicing medicine can do a DRE.
mhm.
And I want to emphasize something, Carol, before I hand over to you, is this that it's a quick procedure. It's very, very quick. I remember the
Correct.
first time my doctor did a DRE on me, man. I wonder if this man if he's crazy, he just put in and out. And
Yeah.
I said, could he really pick up something that quickly?
Mhm.
And then when I get into it now and I understand more, you realize that there's so much information by just putting a little finger, not far in. Before you know it, it's finished.
Right.
So, that's a very important thing to emphasize to some of the guys who are shying away from it.
Yeah, it's a few
It's,
seconds. It's
a few seconds prevent
It's
a
taking
life.
longer than that, and that's not a prostate exam, So
Yeah.
it's a few seconds, Yeah.
All right, Miss Carol, take over. Nurse Bihari, your time now.
All right, thanks, Doc. Again, thanks, Dr. Thomas, for the presentation.
Sure.
Few more questions were shared. Question: how long does it take to get back a PSA result?
That depends on the lab. That
Mhm.
that's a test that actually you could get it back within the same day. And I've had cases where we need it as an emergency, and you have to specially request that from the lab. But in general, I think because of just logistics and efficiency in terms of, I guess, being cost effective, let us say whatever it is, the machine that they use can do a batch of 50. They're probably going to wait until they have 50 samples or 20 samples at least to make it worth their while. It more comes down to the whole, financial aspect of it. But a PSA test could actually be obtained within the same day.
So you're speaking about the financial aspect of it. So roughly, can you share a price range for this
That's a good
PSA if it is
question.
done privately?
Yeah.
Because I know in the public system,
Correct.
public is free.
I think, I don't think it's more than say $2,000-$3,000, It's definitely under 10,000.
Yeah.
I think, it's probably $2,000 to $3,000, not more than that.
And if they were to get it back same day, it could be maybe twice the amount.
The thing is, I don't think that is generally
But we
done.
can check.
We
Okay.
can check, yeah. Mhm.
Okay. There are some myths, of
But
course.
what I would say, sorry, just before that,
Mhm.
getting it back a week later or two, though, is not going to put you at any sort of significant disadvantage. So I'd say, if you say you're getting it back within a week, that's a reasonable time,
Okay.
Yes, go ahead.
All right. So the myths that follow in terms of the men who sit in hot spaces, keep their organ warm all day, like the taxi operators and those who sit on hot surfaces. Those myths, they say that they
Yes.
can get these problems down in their prostate.
All right.
Could you just shed some light on the myths, please?
Right. I don't know that there is an association between that and prostate cancer. What I would say though, in terms of some organs that are close by, that are a part of the male reproductive system also, and that those would be the testes. We actually think that they exist outside of the body because they're supposed to be at a lower temperature. And so for fertility, and for health of overall of the testes, we believe that they should be in a relatively cool environment. So we advise against very tight clothing and very heated environments that would be directly against that. But for the prostate, I don't think that there is any sort of conferred risk. What I'd say is that there are other conditions involved in the prostate, and I suppose significant prolonged exposure to heat may put you at increased risk of inflammatory processes there, but I'm not aware of that. All right, but what I would say is heat in general isn't good, or
it's not a good thing.
No,
yes.
No.
All right, next question. After the
Well,
biopsies,
Carl, certainly for me, we don't like men to have heat down there because it affects their semen.
Correct.
And less their chance of getting their female pregnant.
Correct.
And as you rightly say, that's why God allowed it to hang outside.
Correct.
Whereas the woman ovaries are hanging inside. The Chinese, when they're having problems with in terms of cutting down population, that's why they brought in these sauna and all these things, and they go in these hot tubs and things to keep their sperm low.
Right.
So it's really more for the reproductive needs.
Yeah, that's true.
Beautiful. Thank you for that one. After the biopsy is done, okay, so if the person gets a positive or a high PSA,
right,
and got the biopsy done, how long after the biopsy should the MRI be done, and should the PSA be repeated prior to the MRI?
It's a good question. So you should really wait 6 weeks to do the MRI, because if you do the MRI earlier, then changes from the whole process of the prostate biopsy will distort the architecture of the prostate. And the tissue, the reading that you're getting based on the different images from the MRI may incorrectly, you get an incorrect reading from it. So by right, you're supposed to wait, say 6 weeks. It is start to wait for 6 weeks. And again, some first world countries, they are actually moving to doing the MRI before the biopsy. But as you can imagine, the cost for an MRI and the availability of that doesn't make that such a very good option or option that's widely available. An MRI is like 60, 70, 80,000. Yeah, very few MRI machines, and because there's such a high workload on them, then, invariably they're down from time to time. But yeah, you should really wait 6 weeks to get that MRI. After the biopsy. Yeah.
6 weeks after the biopsy.
Yeah.
And
if it is, so from the biopsy to the MRI. The thing about it though is that usually, unfortunately, in our system, biopsy results, we don't tend to get them earlier than 4 to 6 weeks. So pretty much, by the time you're getting the biopsy report, they would have surpassed that time, which then allows for it to be a reasonable time for them to get the MRI immediately if it is positive for prostate cancer.
And if it is that there's a delay, it means therefore they have to repeat it.
Well, that's in regards to no, that is actually coming from the radiologist. So the radiologist, and they'd probably be able to better speak to that. They usually want a more recent PSA before actually attempting to interpret the MRI images of the prostate. But that is something that's specifically under their purview. I am actually quite happy with the PSA that would have been done 6 weeks prior to that. I would say though, because we use PSA as an indicator for progression of prostate cancer, it does certainly help to have a more recent PSA result. So it certainly helps. But I know the radiologists definitely insist on a more recent PSA before reading the MRIs.
Okay. All right. I think we're coming down to, there's another one. For persons with strong family history of pathology of the prostate, do we wait until age 40 for screening, or should they start earlier?
So a good question. So I mean, yes, age 40 is actually for a high-risk individual. And we have actually adapted that across the entire Jamaican population because we believe that we are a high-risk population. So 40 really is a good age. I wouldn't say you need to be less than 40, unless it is that you have, and I mean, this would be very, very unlikely, you have family members that were diagnosed with prostate cancer at age 40, or God forbid, even less. I don't know that that's such, age 40 is actually quite good. That's for a high-risk individual.
Okay. All right, I'm going to scan through the chat once more. Thank you for that response. I am not seeing any more questions.
Okay.
Just a comment I'd like to make, though, Carl. I know we want to finish.
Yes, Dr. Nepaul.
The responsibility of clients to collect their results, very, very important that we just don't turn our backs and move away. We have had situations where people have changed their address. We don't have a national ID as yet. And I have had some real bad experience, well, one or two, of people having pap smears, for instance, only to use their spouse's phone number and so on. This one was a worker in the grill, consultant doing the pipeline, and the wife, they were living at the Point Village, and the wife used the husband's number, and then he went back to Spain. Nobody knew her, couldn't get in touch with her, and she had cancer of the cervix. I think the same thing will hold for prostate. I think every test that is done, it's your responsibility to follow up with it, not just the healthcare workers. I know the health department has a way of saying, if anything is wrong, we will call you. But I still think you must have some responsibility
Absolutely.
to follow up with it, because we have had some catastrophes where patients turn their back, change their address, change their phone number, and when they're trying to get into them, they are away. That's number one. Number two, the fancy surgery you mentioned, robotic and so on. I know some of us may have relatives abroad who may introduce these things to us. Lo and behold, you have these fancy procedures done, and you track back home quickly, and you have complications.
Yeah.
Complication, be it laparoscopic surgery, be it robotic surgery. And the truth is that we are not really so equipped to deal with some of these complications. So, that's one of the things I want to say. When you tap into the North American or wherever, be careful of some of these things that may not be able to be followed up properly back home, backyard. Yeah, those are the last things.
I might even say
Thank-
something that's a little more controversial, is that, especially with robotic assisted laparoscopic prostatectomy, there was a concern at one point that it was just being driven by, it was more something that the economy was driving because of the great cost involved and what could be obtained from governments to fund for this. But I will point out yet again, the outcomes from an oncological standpoint in terms of cure is no different from the open surgery. I'll give it that blood loss, yes, is a bit more in open surgery than it is for robotic assisted, but most of the outcomes, which will be the important ones in terms of how you do and your cure rates, are pretty much the same. The side effects, the erectile dysfunction, the urinary incontinence, pretty much similar. But but in the hands, obviously, somebody who's very experienced, then you will see probably some differences. But there is no big advantage, or or you feel that you're losing out because you're in Jamaica and it's not widely available.
Thank you, Dr. Thomas. And Dr. Nepaul, you made mention of follow-up, and follow-up is really, really important, because I can tell you, it's not just the fact that the health department would call persons when they are negative, but we have results of persons who we call and it's a wrong number. I don't know why people change phone numbers so fast. It is not easy to get them back, to even tell them about their prostate test results or their pap smear. So the responsibility now would become that of the client to say, you need to follow up on your result. Don't wait on a phone call, because sometimes we just definitely can't get through. I am seeing some other comment in the chat. Seeing where RB says, who should do a DRE? The urologist. If 80% of men don't have DRE done, I am thinking general doctors who have limited experience, they are the ones doing DRE. And another one, I'm seeing some guidelines being dropped, or dropping the DRE as part of the screen and just using PSA. Are you seeing that, Dr. Thomas?
Sorry, let me
Like,
see.
for example, the CBC and other tests, for the men. Any routine tests being dropped? Or they're
Not
taking
as
it
far
off?
as I'm aware. In terms of routine screening,
Mhm.
oh, this says here, British Association of
British,
Urological
yeah.
Surgeons has stated emerging evidence has demonstrated that there is a poor test with a limited role. So sure, there is a suggestion that it is not very accurate, but as I said, we combine it along with the blood tests, and it still forms an important part of the armamentarium. You will notice that they say there's emerging evidence. I don't know that it is a part of standard guidelines. The thing we have to be careful about is that, especially with regards to the US and England, is that the demographic of patients that they have are different from the ones that we have in Jamaica. Predominantly men of African descent here, and unfortunately, that's one strong associative factor. These other countries, for example, I'll tell you, I looked at a study just a few days ago. Greater California, they have a population of 11 million. 10 of that 11 million are not Black, they're of other races. So of course, if a study is done there, it is 1/10 of the men who are of African descent. So in fact, I'll tell you this. In the US in 2012, the US Preventive Task Force actually advised against screening for prostate cancer because they thought that prostate cancer, or the thinking was that prostate cancer is a slow-growing cancer. If you live long enough, you will get it, but you're not going to die from it. But unfortunately, what started happening is that they had a lot more significant increase, uptick. Sorry, I'm saying the same thing in different ways, of men presenting with more advanced disease and dying from prostate cancer. And it actually led to them revising that in 2017 or 2019, I can't remember exactly when, where it's now up to a grade C recommendation, where it's supposed to be what we call shared decision making between you and your doctor, right? So as much as I would say, yes, the rectal exam is not very accurate, combined with the blood tests, there is a decent sensitivity and specificity to combining both in terms of making your diagnosis. And yes, I agree, it is much rarer to detect the prostate cancer in early stages from an examination, right? But there have been those cases where their PSA is normal, but the prostate feels abnormal. It may trigger us to go and do an MRI, which then highlights further places in the prostate that are potentially significant for prostate cancer. A biopsy is done. It shows prostate cancer, and that is somebody's life who is potentially, it's potentially saved, rather than waiting for that PSA to then go up. Remember, as I said, prostate cancer cells actually produce less PSA than normal. It is by virtue of them disrupting that basement membrane that in general PSA, usually there's more of this thing in the bloodstream. So because PSA is not perfect, the rectal exam ain't perfect, but we found that by combining them both, it increases the pickup rate for prostate cancer.
Can I just add something there, Carol?
Yes,
Very, very comprehensive question, answer. In regards to the same Association of Urologists in Britain, emerging evidence, we have to be very careful, as you're saying, Jeremy, with some of these, well, I don't like to use the word first world, but in other demographic areas, because you're not too sure of the cross section of their study. I mean, take even Caribbean. I'm not up to date as to what's now, but I know many years ago, even in the Caribbean, we are predominantly African origin. And I don't know, you can back me up with this, or you can say it's no longer like that. But the English speaking Caribbean countries were not doing as well as the non-English speaking Caribbean countries in terms of Black men. So you find the St. Martin and the St. Thomas and all these countries, they were having better results. And one of the reasons is because of the fact that they are smaller, they were able to be governed better in terms of still have the system of that type of governance that they could collect data and establish a better health system than us. And the education, the social education status were much better than many of the English-speaking Caribbean. So you find that men were able to go forward much earlier for prostate screening than the English-speaking Caribbean. I don't know if that if I'm talking the truth, you can help me.
No, I mean, there is definitely a lot of merit to that. I mean, it comes down to access to health care. And a lot of men in the English-speaking Caribbean, believe it or not, it's probably not very hard to believe, they have limited access to health care. And, some of the things we may take for granted, is not as easy. So even a simple blood test is $2,000, $3,000, $4,000. A lot of men actually wait to get it done in the public health system for free. And I think the National Health Fund now has on board where they're subsidizing that test because it's not as accessible. So, my argument to you would be even, I'm not saying that we're going to go around promoting that we do rectal exams for everybody, but you may have some of the men, for example, with the prostate cancer screening clinics which occur in September here. These large clinics where you may pick up a couple of patients from examination whilst you're waiting for that blood test to come back. So yeah, I think we have to be careful what we take. In fact, I would add, and this may be going off stream, is that same US Preventative Task Force in 2012 that advised against prostate cancer screening, when they looked at the board, the guys who sat together, there was no urologist on that board. It had pediatricians amongst other healthcare workers. That might sound quite crazy to you, but to your point, you have to be very careful where you're getting information from and who they're representing. And even though it may seem as if it's first world country, I'm not saying that you're not guided by a lot of things there, but the conditions may be quite different. Jamaica and the rest of the Caribbean, we've actually decided and we came up with starting screening at age 40. If you go to the US, you'll see that they recommend you start screening at age 55. And it's between 55 and 69. We certainly don't subscribe to that because we certainly see a significant number of younger men who, if you're waiting until age 55 to 69, you may miss, or you're going to miss quite a few.
I mean, can I just add? I
Yeah.
mean, there's a country nearby us
Yeah.
that's talking about prohibiting acetaminophen.
There you go. Exactly. There you go,
For use in pregnancy.
Yeah.
So you wonder what most pregnant mothers use
Correct.
when they're having
They
pain.
have a lot of options. Exactly.
And I'm sure the Surgeon General was not into that. So you have to know where these studies are done and how we're making
Yeah,
it
have to
and
check the
who the
validity of
indicators
them.
are. Yeah.
Thank
All
you.
right. Yes.
There's one last burning question I noticed, and this is repeated. Does Jordan aggravate other cancers once present? And the person wants to clarify if you had mentioned something about it worsening the existing prostate cancer.
Okay. All right. Good question. So no, it doesn't aggravate other cancers once present. So what Duodart is actually a combination drug. It contains two things in there. There's one part of it that shrinks the prostate called dutasteride, if you look at closely at the box. And what that actually does is that it prevents the conversion of testosterone to dihydrotestosterone, which is a very active form that stimulates the prostate to grow. So it's actually given in men who have an enlarged prostate. Now, there are two major trials that actually show that both dutasteride, which is in the Duodart, and finasteride, which is the other major one, both of them are actually associated with a decreased risk for prostate cancer. However, what was noted is that if prostate cancer is diagnosed, there was a slightly increased chance of it being a more aggressive cancer. So there was some concern saying, hold on, although I'm at a decreased risk for getting prostate cancer, but if I get it, it's going to be on the more aggressive type. So that is what I was actually referring to. But what I will say is that the risk of that is so low that we don't think it is as significant, or it is to say that it is dangerous to take Duodart or Avodat or finasteride or any of those drugs that we use to shrink the prostate. And remember what I said, it actually is associated with a reduced risk of prostate cancer overall.
And I'm sure the person who asked the question is saying thank you.
Okay, I am most welcome.
Yes.
You're welcome.
Miss Carol, Miss Carol, one more thing I want to say before I sign off fully now. I just want to tell Jeremy that, boy, this is really a good presentation. Up to recently, I saw over 100 people were still on. I guess we got on to 90 now. But let me just say this as my last thing. I've had patients very concerned about they are taking the same medication and they notice that their father also taking it for his prostate problem. There are some drugs, as you're saying, that overlap. For instance, one of them is, we call it in obs and gynae, LHRH analog, like Lucring, Lectrum,
Right.
that type of thing.
Leuprolide, Lectrum, yeah.
Yes, and we use it to treat endometriosis, we use it to treat
Yes,
menopause, everything, all sorts of things in gynae. But you also use it to treat cancer,
we
right?
we do.
Of the prostate.
Yeah.
So you may see some drugs that we use in the female gynecological thing being used to treat prostate cancer.
Oh,
You
for
know?
sure.
Yeah.
With merit, with merit, it's
With
evidence-based
merit, yeah.
medicine. So yes, for sure, yes.
Thank you, Dr. Nepaul. Any closing remarks? Because I see you still have your summary slide up. Any closing remarks, Dr. Thomas?
No. It's just left there to still send
As a
home the
reminder?
message that most common cancer in Jamaica, screening starts at age 40, blood test and examination, or even if you're leaning towards saying you don't want the examination, at least the blood test. Just remember, early prostate cancer, no symptoms or signs. So you're not trying to wait for that, right? A lot of the times what people refer to or think, men, when they come in and they're saying, boy, doc, I'm getting up more often at nights, urine is slowing down and so on. That's a whole other topic, which we can do another time. That really refers to benign prostatic hyperplasia, or BPH, which is a non-cancerous enlargement of the prostate gland. That is totally different from prostate cancer, right? Which has a much graver prognosis if it is caught late. All right. So age, race, family history are the risk factors, non-modifiable. So, the message is, the take-home message is screening. Age 40, once a year, and you will do pretty well if you're caught early. All right. That's the good news at the end of all of it. It's curable, and you can go on to live your full healthy life, be there for you, not only yourself, but your family and your loved ones once it's caught early.
Awesome. Thank you so much. And I would love to continue our conversation. So where would I find you?
Well, I believe the host mentioned where I can be found for the purposes of this presentation. So,
as when she mentioned it, about 55 people were on at the time. So I don't think
okay, no problem. So I'm at Royal Medical. I mean, I'm there on some weekends. I am actually based though in Montego Bay. So I'm at a few places. So quite a few of the medical complexes around in Montego Bay Hospital, Holiness Health Center, Bay West, amongst others, Med City. You can find me at most places if you call and you ask for where the urologist is. Because even on occasion I'm in Kingston at Dunrobin Medical. But I would say just ask around. I'm at a couple of places, even in South, right?
Okay.
Yeah. So I can be found, And if you go to my Instagram
and for those
page,
who
I
need
think it does
additional,
come out. Sure.
Beautiful. And for those who still need to find you, we'll find a way to share the information so that once you can find Dr. Jeremy Thomas.
Right.
And if Mrs. Nepaul has nothing else to add, I just want to say thank you, Dr. Thomas, for a very informative session. You would have learned a lot, and I don't think we missed anyone's question this evening. Thank you to Dr. Nepaul for being the moderator, the host, and facilitator that you are. And again, thank you, Dr. Thomas. Thank you, Dr. Nepaul, and thanks to the Flame families. And so on behalf of the Flame families, for all those who are on, we say thank you for staying on with us up to this hour. And we can be reached in conversations on WhatsApp and YouTube. So reach out to us and see how best we can support you while you support your loved ones going through their process of screening. All right. So you take care. Have a good night.
Just before you go, Carol,
you're there.
There is that WhatsApp that you actually sent to me. I'm saying it's 4 minutes. If anybody wants to listen while you're going off, but it's really something that I'd want most of us to hear. But those who are really hungry and tired, you really don't have to. But just listen to it. Kevin, are you there to put it on for me? Carol, that's the one that you sent me, right? It's coming up. Yes, doing screen sharing there.
While it's coming up for persons who don't know it, This gentleman has a radio station that some of you would have listened to, and he's also sharing his testimony
Why
and
big stone
what he's going
want
through.
to talk about because prostate cancer has the highest mortality rate in Jamaica. Prostate cancer kill more people than kill more black men than anything else. Not even gunshot that take out black people in Jamaica. Black man like how prostate cancer do it. No, I know it's a whole heap of people, especially man who have locks, get stigmatized. And I talk about boy, them now want do not test the man push up no finger. I understand the stigma, I know where it come from. But between me and you, early detention can save your life. See? Go get your test, brother. Don't be like Big Stone, because I never know say me have this thing here. Until I walk up and down with it for over 2 years. Can you imagine? An intelligent, articulate black man like me, I walk around with prostate cancer for 2 years. I don't know. I don't even get into the symptoms. See? We don't get into the symptom of prostate cancer, and we just allow a disease like this, we just take control away. We cannot afford to make that happen. I cannot afford. I want to be a living testimony so that the Jamaican brothers out there can understand that prostate cancer is not a joke. Prostate cancer will kill you. You hear me say? No. It's a killer. And you know what it do to you? It strip you. It take away your manhood. It take away your ability to walk. Because right now, I'm not telling you, no pain me I feel. Me dip on my back right now, no pain me I feel in the hospital. Them just have to put me on a thing named Petidine. And Petidine is the same thing like morphine or Voltaren, one of the top painkillers them, to ease my pain. Saying so, I want them tell your loved ones them, tell your father, your brother, your uncle, say don't worry about no stigma. I don't watch no face and talk about, boy, I don't want no man, push up, finger, and so on. See there? At this Big Stone above. See, me have a catheter for walk with because I never do my due diligence and I never follow up on a disease. See, prostate cancer can be rectified at an early age. Like for instance, suppose them catch it when it just a buzz in the prostate. A whole heap of treatment can do to lick it out, you know. A whole heap of things can be done. But if you wait until it take over your body, brother, like how it happened to me, because right now I talk to you, I feel some rago, cargo pain, and I continue to videotape. Because boy, you know what I go through. Big Two I go through hell, Big Two I go through hell. When me for pass me you and I not easy to get the brother. And some wicked pain me I feel it. And guess what, the pain come in all at night time. At night time at 1 o'clock this morning the pain attack me. The pain attack me at 1 o'clock this morning. And when the pain attack you know, you're alone after you bear it, you know. So go out tell a friend, your brother. Get checked. Check your prostate. Get tested. Tell a next door friend. Because it's a thing that can, if you catch it early, it can save your life.
Okay, good night, everybody. Thanks for joining in. And thanks again, Doc. We really enjoyed you.
Good night.
Night, night.